Okay, we might get started. There's still quite a few people joining, but in the interests of getting everything finished on time, we better start on time. My name's AMA Khorshid, President of the AMA, and I'd like to welcome you all to the Sugar Blinded webinar, which I'm hosting today on behalf of the AMA for our members and for you to hear from some really impressive guests to help us help guide our advocacy in these really important areas. Before we do get started, I would like to acknowledge the traditional custodians of the country where we're all meeting today throughout Australia and their connections to land, sea and community. We'd like to pay our respects to their elders past, present and emerging, and extend that respect to any Aboriginal and Torres Strait Islander peoples who may be joining us on this call tonight. I'm very pleased and I think we're honoured to be joined today by Dr. James Muecke and James Martin to discuss some really important public health reform. I'm going to start the webinar with just a brief introduction on some of the AMA thoughts in this area, and then I'll introduce you to our two panellists who are of course the reason we're all here tonight. In terms of interaction, we would be keen on some questions at the end of the two presentations. So please, if you've got questions for any of our guests or for me on behalf of the AMA, please type them into the chat and I'll have the opportunity to put those questions to our panellists as we go through the evening. We will be finishing after an hour or so. To get started on the AMA view, I took over the presidency of the AMA just a few months ago, and one of the things that I was able to point out right at the start was that some real reform on the treatment of sugar in our community should be part of AMA policy. We need to be a strong voice on public health, and we have existing policy that's well supported throughout the world by many health leaders around sugar. And its effect on obesity, diabetes, cancer, and all sorts of other areas within our health system. More than half of the free sugars consumed by Australian children every day come from sugar-sweetened beverages, and hence they have been the focus of AMA policy to date. The products are marketed in a way that it can be really cheap to purchase large containers rather than small containers. And often you see sugar-sweetened beverages cheaper than water at retail outlets, encouraging not just the wrong consumption, but greater consumption of these products. Now, we do have policy on a sugar-sweetened beverage tax, and some analysis that's been done on that in the past has found that a 20% tax on just those beverages would, over a long period, 25 years, see 16,000 fewer cases of type 2 diabetes, 4,500 fewer cases of heart disease, and over 1,000 fewer cases of stroke. We'd see more Australians living longer and millions of dollars of healthcare costs saved. And to be honest, I wonder if some of that is actually an underestimate. The benefits of a tax on sugar-sweetened beverages will obviously extend beyond sending a price signal. It also generates some money, and that money can be used on further evidence-based targeted measures to improve the health of our community. And we all know that governments spend far too little on preventive health and nowhere near the AMA policy of 5% of the health budget. Now, we're of course not alone in campaigning in this area, and I'd like to introduce our two guests now. Dr. James Muecke is the 2020 Australian of the Year, an ophthalmologist from Adelaide and a passionate advocate for preventing more Australians from losing their sight to type 2 diabetes by looking at the underlying causes of that. And you're about to see a really impressive presentation, and the AMA is keen to get on board with this sort of reforms. Dr. Muecke graduated with honours from the University of Adelaide Medical School in 1987, and following an internship, he lived and worked as a doctor in Africa, and subsequently as an eye surgeon in the Middle East, battling malaria, wild animals, and rebel soldiers. Sounds quite interesting, James. Maybe you can share that with us too. He founded Sight for All in 2008, turning his boundless energy into a fight against blindness in the Aboriginal and mainstream communities of Australia and some of the poorest countries in Asia and Africa. Sight for All's comprehensive and sustainable projects are now impacting on the lives of over 1 million people each year. His commitment to social impact and humanitarian endeavours has earned him a string of awards, in addition to Australian of the Year, including an Order of Australia in 2012, the AMA's President Leadership Award in 2013, and Ernst & Young Social Entrepreneur for Australia in 2015. We're also joined today by Jane Martin. Jane's main role, I guess, amongst many, is to lead the Obesity Policy Coalition, a partnership between the Cancer Council of Victoria, Diabetes Victoria, and GLOBE, the WHO Collaborating Centre for Obesity Prevention at Deakin University. The coalition advocates for policy and regulatory reform to prevent overweightness and obesity, with a focus on food marketing, labelling, and of course pricing measures. She oversees the Cancer Council's Healthy Weight campaigns and is involved in advocating for alcohol policy reforms at a Victorian as well as a national level. For more than 30 years, Jane has worked in public health advocacy, engaging in tobacco control, alcohol policy, and obesity prevention. She's active in the media as a commentator and advises state and federal governments on obesity policy. Jane was awarded a Deakin Honorary Doctorate for her contribution to public health advocacy in 2018 and the Public Health Association's President's Award in 2019. She's co-chair of the National Alliance for Action on Alcohol and president of the Australian New Zealand Obesity Society and a Churchill Fellow. That was a long introduction to two very eminent guests. I'd now like to hand over to James, who's going to take us through his presentation. Thanks, James.
Thank you so much, Omar, and thank you to the AMA for hosting the webinar this evening. I'll just go ahead and share my screen so we can get started. So as Omar said, I'm an ophthalmologist and I've been an ophthalmologist now for 30 years. And for 30 years, I've been dealing with the consequences that diabetes inflicts on the eyes. Every year, I'm actually seeing more and more people who are losing vision, even going blind due to diabetes. Excuse me, in particular type 2 diabetes, which is a largely preventable dietary disease related to the consumption of too much sugar in our modern diet. You imagine waking up one morning completely blind. Impossible to comprehend, isn't it? One of my patients has had exactly that experience. His name is Neil Hansel, an everyday Aussie bloke with a wife and 4 kids. He constructs light machinery for a living, and he also has type 2 diabetes. And a few years ago, at the age of 50, diabetes changed Neil's world forever. Unfortunately, he'd neglected his disease, and he paid the price. He went to bed one evening with normal sight, woke up the next morning blind in both eyes. One of my colleagues worked really hard to try and retrieve his sight. Unfortunately, it was too late. Neil was to spend the rest of his life in darkness. This is how Neil sees the world these days.
Basically, I think I would describe it as seeing everything as as emotion, not as an actual vision. The images, unfortunately, aren't clear. The images are basically what you see of a day through your eyes is what you see of a night through your eyes. So there's no clarity. I see black figures as people or animals or trees, just black onto a greyish background.
Neil lost his driving licence. He lost his independence, and he lost his ability to teach the javelin, which was his hobby. In fact, it was a passion that gave him incredible joy. But the thing that upsets Neil the most is that he can no longer see the smiles, the beautiful smiles on the faces of his wife and his grandkids. This is a picture of Neil's wife and 2 of his grandkids. This is how he should see them. And this is the reality. Neil has been irreversibly blinded by sugar. And Neil is not alone. He is just one of over 150,000 Aussies with sight-threatening eye disease due to diabetes. So how does diabetes threaten the sight? Well, for us medical practitioners in the audience tonight, diabetes damages the blood vessels throughout the body, including the retina, the light-sensitive layer of tissue that lines the inside of the backs of our eyes. This is a picture of the central vision area of a retina in a patient with type 2 diabetes. And this is that same eye, a short time later. Diabetes can cause bleeding inside the eyes that can take away the eyesight in an instant and sometimes permanently. The important point here is that nearly all of the loss of vision and blindness due to diabetes is preventable or treatable, something like 98%. And yet to avoid the blinding consequences of this disease, patients with diabetes need to have their eyes checked on a regular basis. Of the 1.7 million Aussies with diabetes, more than half Actually, well over half are not having these regular, all-important, sight-saving eye checks. That's why it's now become the leading cause of blindness amongst working-age adults in this country. It's also the fastest growing cause of vision loss in Aboriginal people. So for me, as an eye specialist, to see people going needlessly blind due to this condition makes me upset. But the thing that makes me really angry is that this disease should not be happening at all. Type 2 diabetes was a disease that was virtually non-existent in the 60s. In these days, we're seeing roughly 250 new cases every single day. So this evening, I'm going to talk to you about type 2 diabetes, how it's arisen, why it's a growing epidemic, and I'm also going to explore some strategies to deal with this rising tide of a disease that's a serious threat to our health system and our society. Now, I mentioned that type 2 diabetes is related to the consumption of too much sugar in our modern diet. When we talk about sugar, we often visualize table sugar or sucrose, and this is the most common additive. It's the thing that we stir in our tea and coffee. But it's important to recognize that there are another very abundant form of sugar, and these are the refined carbohydrates. So products such as white flour, white rice, white potatoes, and the foods made from these are all virtually pure starch, and starch is simply long chains of glucose which are broken down into single molecules of glucose when they reach the gut. So when you're ingesting refined carbohydrates, you're pretty much ingesting pure sugar. And it's important for us as doctors to remember that sugar and carbs, and particularly refined carbs, are nutrient poor and non-essential. There's not a single biochemical process in our body that demands that we ingest sugar and carbohydrates. And yet, our Australian Guide to Healthy Eating, which is based on our dietary guidelines, is packed with refined carbohydrates, white rice, a variety of breads and pastas, and white potatoes. And there are also a number of high sugared products, or relatively high sugar products, tropical fruits, low-fat dairy, baked beans, and processed foods. So let's go back to that picture of sucrose. So sucrose is made up of 50% glucose and 50% fructose, and the body handles these two substances in quite different ways. So let's look at them each in turn. So firstly, glucose. When glucose is absorbed into the bloodstream from the gut, it triggers the release of the hormone insulin from the pancreas. And the insulin helps move the glucose into every cell of our bodies where it's either stored or used as an energy source. When I talk about glucose metabolism, I like to use the analogy of a subway train in Tokyo, where the train carriage is the cell, the passengers are the glucose molecules, and the subway conductor is the insulin. So with prolonged and excessive glucose intake, the cell becomes full of glucose. The insulin level rises to help try and push more glucose into the cell, but it reaches a stage where it can no longer push any more in, and we become what's called insulin resistant. Now, at this point, there's an overflow of glucose back into the bloodstream, and this is taken up by the liver and converted initially into glycogen, where it's stored. The glycogen stores are limited, and so then the liver starts converting the glucose into fat, which is exported away from the liver and stored in healthy fat cells throughout the body. It's actually a type of protective mechanism. When the production of fat outstrips the ability for it to be exported away from the liver then starts to take on that fat, and we develop what's called a fatty liver. Now, we all know what a normal healthy liver looks like. It's a deep dark red color, right? This is a picture of a fatty liver. You can see it's a deep yellow color because it's suffused with fat. Now, a great example of a fatty liver comes from the French culinary delicacy foie gras, which is created by force-feeding geese refined carbohydrates in the form of high-starch cornmeal. And a fatty liver can develop in these unsuspecting creatures in 10 to 14 days. In humans with excessive fructose intake, a fatty liver can develop in under 2 months. So let's look at fructose. Fructose is that molecule of sugar which gives sugary products their sweet flavor. It's not recognized as a food by the body. It doesn't trigger the release of insulin. And it actually suppresses our appetite control system. When it's absorbed into the bloodstream, about 100% of it is taken up by the liver, and a third is converted immediately into fat. So it's actually far more toxic than glucose and giving rise to a fatty liver. This is a picture of a normal healthy liver. You can see the densely packed cells. This is a fatty liver. You can see it's distended, and those white spaces are the cells which are full of fat. Now, it takes on average 13 years to develop type 2 diabetes after we've developed a fatty liver. In children, they can develop type 2 diabetes within a couple of years. Now, it's a complex metabolic process, and what happens ultimately is that the liver stores fat, become saturated, and so the liver can take no more fat on. So it then starts to export the fat away from the liver, and it's exported as triglyceride, which is actually harmful to our health. And it's a high triglyceride level in the blood combined with a high insulin level, which in turn leads to the development of the fatty plaques, which block the blood vessels throughout the body. And this is what leads to the myriad of life-changing and life-threatening consequences of this disease. So blockage of the fine blood vessels in the body can lead to impotence. It can lead to numbness, tingling, pain of the hands and feet. And as we saw before, it can lead to bleeding inside the eye. The other thing it can do is cause macular edema. Now, this is a picture of a patient with type 2 diabetes, what we call an OCT scan in ophthalmology. The top picture is the right eye, and the top right picture is the way the cross-section through the macula, the central vision area, should look. The one below it is the left eye, and you can see that little raised area at the fovea, the very center of the central vision area, which is edema or swelling, which is building up there due to leakage of the very fine blood vessels, which have been damaged due to the diabetes. And when this happens, the patient starts to experience blurring and distortion of vision, and we need to then implement treatment. In this particular situation, we inject an antibody into the eye, which helps seal up the leaky blood vessels and hopefully stabilize or even improve the vision. And this is a picture of me about to inject a patient with diabetes with macular edema. I have reached out to Medicare and received the stats on what we call intravitreal injections for diabetic macular edema. We started giving these back in 2016, and you can see over the 4 years leading up to the end of last year, a steady increase, which really mirrors the rise in type 2 diabetes in our society. Last year, over 93,000 injections were given, and I suspect we're up over the 100,000 mark. So this is 100,000 injections into eyes that absolutely shouldn't even be happening. So damage to other fine blood vessels in the body can also have quite devastating consequences. Dementia is one of the very serious effects of type 2. 70% of patients with type 2 diabetes will ultimately develop dementia. So this is a disease that impacts not just on the individual, but more broadly on the family as well. Damage of the fine blood vessels of the kidney can lead to kidney failure. When the kidneys fail, the patients need to have their blood filtered by dialysis, sometimes up to 7 hours a day, 4 days a week. And I've calculated that every year in Australia, 4.5 million hours are spent by patients with type 2 hooked up to the dialysis machine. So this is time lost to family and friends, to their workplace, and to the things that they love to do. Damage to the larger blood vessels in the body can have really, really awful consequences. And one of these is gangrene of the feet. And this is the second most feared complication after loss of vision. This is a patient with gangrene due to type 2 diabetes. And of course, such a foot needs to be amputated. Every year in Australia, over 4,000 amputations are performed for gangrene due to type 2 diabetes. And here's our friend, Neil Hansel, in his hospital bed the day after his left leg was amputated in March this year. In fact, it was his 9th amputation after he'd gone blind in both eyes. Neil has also had 2 heart attacks. And so type 2 is also a deadly disease. 80% will die of a thrombotic complication such as heart attack or stroke. It's now the 6th biggest killer in our society. If we realize that it plays a really crucial role in the top 3 killers, heart attack, dementia, and stroke, it also plays a critical role in hypertension and cancer, then perhaps type 2 is the biggest killer in our midst. And if we look at the current situation with the COVID pandemic, in the first few months, there were 102 deaths due to COVID-19. Tragic death, absolutely. But in the same time period, over 5,000 deaths due to type 2 diabetes, deaths that went largely unrecognized. And if you have chronic disease such as type 2 diabetes, you're 12 times more likely to die from COVID-19. A very sobering reminder at this very important time in our history. It's also a very expensive disease, costing our health system about $20 billion every single year. But if you factor in all of those other diseases, I suspect it's far more than this. It may even be closer to $100 billion. So how did this arise? Well, humans are hardwired to love and seek out sweet things. It's an ancient survival mechanism that helped our early ancestors to survive extended periods of fast, which are common in early humans. It also allowed them to avoid bitter and potentially poisonous foodstuffs in their environment. Prior to the 1600s, sugar was an expensive commodity. It was the domain of healers and holy men, and an indulgence that could only be afforded by the wealthy and the powerful. Over the next 300 years, the rising availability and popularity of sugar due to the booming sugar trade led to diminishing costs, turning sugar from a luxury item to an everyday necessity. These days, sugar is cheap and absolutely everywhere in our lives. Things took a turn for the worse, though, in 1980 when the Dietary Guidelines for Americans was released. It was noted in the decades after World War II that there was a rise in heart attacks, and this was thought to be due to a fatty diet causing fatty blockage of the coronary arteries. And so on no strong scientific evidence, the recommendation was to decrease our fat consumption to 30% and to compensate to increase our carbohydrates to 60%. And rather than see a downturn in heart disease actually soared, and along with it, type 2 diabetes. In fact, since 1980, there's been a 4-fold increase in type 2 diabetes globally. And this has been more profound in some countries and communities. In China, for example, there's been more than a 10-fold increase in type 2 diabetes since 1980. And this is somewhat paradoxical because the Chinese diet is high in refined carbohydrates in the form of white rice. But what we've noted in Asia in recent years is the rising sugar consumption, which is amounting to about 5% every year. This is a disease that's been devastating the Aboriginal people of this country. Since 1980, there's been an 80-fold increase in type 2 diabetes, and I have no doubt that the consumption of sugar, refined carbohydrates, and the highly processed foods is driving this. And if you look at the Australian Guide for Healthy Eating for Aboriginal and Torres Strait Islander people, once again, it's packed with refined carbohydrates and sugars and products relatively high in sugar. And type 2 has also been a major problem in the lower socioeconomic areas of this country. This is a map of Sydney, and you can see the red areas, the areas where the highest prevalence of type 2 diabetes is in Greater Western Sydney. In fact, 50% of adults over the age of 24 in Greater Western Sydney now have prediabetes or type 2 diabetes for the first time in our history. It's now affecting our kids. This was a disease that used to be called maturity onset diabetes. In Australia, we now have over 1,100 Aussie kids and teens with type 2. And this is a global phenomenon. In 2001, less than 3% of all cases of diabetes were due to type 2. And in just a 10-year period, it's risen to almost half. And we now have close to 40,000 young adults with type 2. And this is going to have a severe impact in the coming decade. It's actually been modelled that this will result in a loss of $3 billion worth of GDP by 2030 due to lost productive life years. And there's a very famous case in the United Kingdom of a 3-year-old child with type 2 diabetes, a child that had excessive consumption of sugary drinks, with even had children in this country as young as 7. So what are we going to do about this? If we're going to call this a dietary disease, there's got to be a dietary cure, right? It should be as simple as reducing our intake of sugar, refined carbohydrates, and highly processed foods. It should be this easy, but there are a number of factors which make this a difficult thing to achieve. And earlier this year, when I was giving this some thought, I came up with the concept of the 5 A's of sugar toxicity: addiction, alleviation, accessibility, addition, and advertising. We'll go through these each in turn. So firstly, addiction. Sugar is highly addictive. It's been shown to be as addictive as nicotine. Its consumption activates a reward center in our brains, leading to the release of the neurotransmitter dopamine. It's what makes us feel good. It's what makes us want to do it again. It's what gives us those cravings. Like drugs, the more we ingest, the more we need to give us that feel-good hit. So it becomes a vicious cycle that's really hard to break. Second A is alleviation. We often use sugar to alleviate stress or to make us feel better when we're down. When we're stressed, the body is flooded with the stress hormone cortisol. The brain needs to balance this up by releasing feel-good chemicals such as dopamine. And sugar, as I've said, does a very good job of this. As I mentioned before, sugar is everywhere in our lives. You can't walk into most service stations without being confronted by a wall of confectionery. And you certainly can't check out from most supermarkets and stores without being enticed by soft drinks and chocolates. 90% of all food at checkouts in Australia are junk food, and 30% of these are on sale in any one week in the major supermarket chains in Australia. Fourth A is addition. An astronomical amount of sugar is added to our food and drink, something in the order of 75%. This is particularly problematic in remote communities, particularly Aboriginal communities, where sugary food and drinks are in abundance, and cheap and fresh and healthy foods are scarce and often quite expensive. So finally, advertising. Our world is flooded with ads and TV commercials for sugary products, often in the most insidious and predatory of ways. And this has been going on quite literally for decades. So how are we going to deal with this? Well, to me, it's going to take resilience. And when I talk about resilience, I like to use the analogy of Mr. Spock from Star Trek. He's a very cool-headed and resilient character, isn't he? I know what he'd do. He'd look to the smoking epidemic to see what's causing its decline. Back when Spock first graced our screens in the early 50s, smoking was socially acceptable. In fact, in the years after World War II, something like 80% of men smoked cigarettes. Have a look at this ad for candy cigarettes from the 50s and the caption on the packet, "Just like Dad." But the realization of the health dangers of smoking in the 60s, the subsequent banning of advertising for cigarettes, the taxing of tobacco products, and the rollout of hard-hitting and graphic awareness strategies such as these, we all know very well, have all made smoking socially unacceptable. And as a result, smoking and smoking-related diseases and deaths are on the decline in most countries. Not so sugar consumption, type 2 diabetes, and its complications, which are on the rise. So we're going to need to engage this same resilient approach in dealing with the 5 A's of sugar toxicity. For addiction and alleviation, it's about awareness. It's about personal awareness. The fact that sugar is highly addictive and that we're using it to alleviate stress in our lives. And for the other 3 A's, it's about accountability of businesses and of industry and ultimately of the government to do the right thing by the people of Australia. So let's look at these each in turn. So firstly, addiction. I suspect much of the world is addicted to sugar. I certainly was, and almost certainly still am. The thing that I love the most is ice cream. The bigger, the better. In fact, the worst punishment I could receive as a child was to be sent to my bed after dinner without ice cream. And there's rarely been a day since when I haven't had a bowl of this creamy treat. But I got a shock earlier this year when I found that I too have an early fatty liver. In fact, this is a picture of my fatty liver. And this gave me a bit of a shock. And I immediately went into a sugar detox. And for me, this was giving up the heavily sugared products in my diet. So the fruit juices and soft drinks, the chocolates and confectionery, the biscuits and cakes, and sadly, for me, the ice cream. And as soon as I did that, on day one, I started to experience withdrawal symptoms, headache, irritability, clouded thoughts, fatigue. It's much tougher than a coffee withdrawal. And over the next few days, symptoms built up along with the cravings, which were absolutely intense. But after day 3, things started to ease off. And these days I can walk past the freezer after dinner and not have to reach in and grab an ice cream. Now, for those of you who know me, I'm certainly not obese and I'm not even overweight. I'm tall and thin. I'm actually what they call toffee. Thin on the outside, fat on the inside. What's interesting, in the United States, there are now more thin metabolically unhealthy people than there are fat metabolically unhealthy people. And I suspect much the same is happening here in Australia. So I'm not hardline about this, and I'm certainly not wanting to be preachy. I still want to be able to go out to dinner and enjoy a dessert. I still want to be able to receive a mint chocolate frog for my birthday. And I still want to be able to have the occasional ice cream, just not every night. For me, it's been a physical dependency. But for many people, I suspect the addiction is much, much deeper. We may need to engage helplines and self-help groups and psychological counselling, as we've done for cigarette smoking and alcohol. Second A, alleviation. Rather than reaching for that block of chocolate when you're feeling down, why not take the healthier option? Go for a walk in nature, somewhere beautiful. Listen to your favorite music. Reach out to someone who's having a tough time. Do a good deed. These have all been shown to be as effective as sugar in countering that cortisol reaction that's flooding our bodies during anxious times. Third A is accessibility. There are a number of strategies that we can engage here. This is 2 vending machines in the foyer of the Women's and Children's Hospital here in Adelaide. I took this just a couple of months ago. And these are 2 vending machines in the Adelaide Medical and Dental School, our bastion of health in this city, packed to the brim with sugary products. So I wrote to these institutions. In fact, I wrote to all of the universities in South Australia and our Women's and Children's Hospital, asking them to remove the sugary products from these machines. And fortunately, they've now each have started to implement strategies to do this. Another obvious thing would be to remove sugary products from checkout counters and supermarkets where they're preying on our addictions, they're preying on the vulnerable, and they're preying on our kids. I've written to all of these stores and supermarkets. I've actually met with Coles and Woolies. And at this point in time, only 2 have taken up. Australia Post has now removed sugary products from over 700 of their corporate stores checkouts. And Foodland Group here in Norwood are now in the process of moving the sugary products away. I'm yet to see anything from these other supermarket chains. And this is one of the checkouts at the Norwood store in Adelaide, the Foodland store, the packets of nuts. It's the sort of thing that we want to see at checkouts, not all this sugary crap. Fourth A is addition. I don't know about you, but I can barely read those nutritional labels on the packets of sugary products, on the packets of foodstuffs, let alone understand them. And they certainly don't tell us the amount of added sugar that's contained within. We need a clear and transparent labelling system that clearly indicates the amount of added sugar contained within. We have a Health Star rating system, which is flawed. It's flawed because it's voluntary. And at this point in time, only about 30% of manufacturers are using it. It's also flawed because there are a number of inherently unhealthy products which have received a healthy rating. And orange juice is one of these. A glass of orange juice has received 5 stars, and yet it has almost as much sugar as a glass of cola. And this is where the rather contentious issue of a tax or a levy on sugary products comes in. There is some solid evidence and good reasoning behind this. If we look at sugary drink consumption in the 10 years leading up to 2017, it increased by 30% in Australia. Sugary drink consumption is to diabetes in many, many studies in many countries. And a levy on sugary drinks has been shown to reduce purchase and consumption in different countries. So it certainly makes sense to me. And as Omar mentioned, it's been modelled that a 20% levy on sugary in this country would raise over $600 million, which could be then used to fund health initiatives and health inequalities that exist in our society. So the final thing is advertising. And again, there are a number of strategies that we can use here. And the obvious one would be to remove the sugary products on our TVs when our kids are watching TV. I've written to the Broadcasting Commission, the Australian Communications and Media Authority, and at this point in time, I've had absolutely no word. Another obvious thing would be to remove ads for sugary products from government buildings and services such as trams and trains. And we need to replace these with a hard-hitting strategy to broadly raise awareness amongst the Australian public of the multitude of health dangers of excessive sugar intake, not just obesity and type 2 diabetes, but also tooth decay. So dental caries, well, sugar is the leading cause of dental caries in our society. 40% of 10 to 12-year-olds now have caries in their adult teeth, and it's the leading cause of surgical admission for our children. But there are some positive messages, and there's a real opportunity here. Not only is type 2 diabetes a preventable dietary disease, it's also potentially reversible in many. There are now 3 proven methods to put type 2 diabetes into remission: very low-calorie diet and bariatric surgery. Why is this not being shouted from the rooftops? And I'm a big advocate of a low-carbohydrate diet, and there are now over 100 controlled clinical trials to put type 2 diabetes into remission. And this is just one example. In a 10-week period, over half of patients in this trial were able to put their diabetes into remission with a low carbohydrate diet. This is something that needs to be embraced by health practitioners and educators across this country. And our Australian dietary guidelines are outdated, they're flawed and they're biased, and yet they're very powerful. They actually inform what's eaten in schools, childcare, aged care, our hospitals, the Defence Force and prisons. They also inform our army of health providers and educators, government policymakers and the food industry. And over thousands, quite literally thousands of low-fat products have been created due to the demonisation of natural saturated fat in the dietary guidelines. Even Diabetes Australia recommend people with diabetes should follow the Australian dietary guidelines. The very people who should not be having a high-carb diet are being encouraged to eat carbohydrates. It makes no sense to me. And even our Royal Australian College GP Management of Type 2 Diabetes Handbooks recommends eating according to the Australian dietary guidelines. This absolutely needs to change. The guidelines themselves say they're intended for the average healthy person. But if we realise that over 2/3 of Australian adults and 1/3 of our kids are overweight or obese, then we are not healthy. We don't need guidelines for healthy Australians. We need guidelines for unhealthy Australians, people with insulin resistance, pre-diabetes and type 2 diabetes. And the guidelines need to stop demonising the natural saturated fats in our diet, products, foods that you can see here on the screen, but also whole fat dairy, unprocessed meat, eggs and dark chocolate have never been associated with an increased risk of cardiovascular disease. This is critical information that needs to be known and understood by the Australian public. And we need to be encouraged to eat real food, not this highly processed and packaged junk that we're eating by the truckload. And we do need to see hard-hitting strategies to raise awareness of the multitude of health dangers of type 2 diabetes. I'm now going to play you a very quick ad, which I created for Sight for All a couple of years ago.
I should have kept my medication up and I should have followed the plans that were given to me by my doctors. I woke up one morning completely blind. Thought I was dreaming, went back to sleep for an hour, woke up and I was still completely blocked off. My wife's face when we went to bed. That was the last clear image I had.
It's a pretty powerful 30 seconds, isn't it? Now that ad played back in late 2018 for 6 weeks nationally on Channel 7, but it played as a community service announcement, so probably it was only seen at 2 or 3 o'clock in the morning. We need to see such ads across all channels during prime time and for extended periods. To me, it's all about raising awareness and education. These days, would you leave a pack of cigarettes on the kitchen counter for your kids to enjoy? Absolutely not. So why leave a bowl of sugary treats? We need to exchange that bowl of sugary treats for a bowl of nuts, for example. We need to educate our kids, and yet we can't educate our kids until we know and understand ourselves. And how about those soft drinks in our fridge? Perhaps this is their gloomy future. Perhaps soft drinks, like smoking, we need to make socially unacceptable. Now, I'd just like to leave you with one last message from Neil Hansel from his hospital bed the day after his left leg was amputated.
I had a little joke the other day and I put my hand up and I had a grain of sugar between my fingers and I said, "Meet my killer." And people were trying to see what was in my fingers and all it was 1 grain of salt, 1 grain of sugar. And that's what it takes. You know, we, as a society, we have to do something. We've got to make people aware that the more sugar we intake, the worse this is going to get. And it's not good. It's not good.
It's not good, is it? It's not good at all. As an eye specialist, I never want to again see another patient going needlessly blind due to their diabetes. As doctors, we should not be seeing the life-changing and life-threatening consequences of a preventable dietary disease. And as Australians, I truly believe it's time to put an end to type 2 diabetes. Thank you very, very much. I'm just going to share with you just one last slide. In fact, these are just a bunch of social media handles. I'll put in the chat line in a moment. So I'll stop sharing my screen now, and I'll hand back to Omar, and look forward to hearing from Jane. So thank you very, very much.
Thank you so much, James. I'm sure all of our attendees have really enjoyed that presentation, and I think your messages are very clear, particularly around things that we haven't really thought too much about, like are our guidelines actually completely wrong, and is diabetes truly a reversible disease, one that we really need to change our approach to. And we've already got some interesting questions there. Before we get to the questions though, we have Jane Martin now to tackle, I guess, the other side of the sugar equation, which is obesity, its relationship to sugar, and what we need to be doing as a society to address our obesity epidemic. Thanks, Jane.
Thank you, and thank you very much for having me. And it's great to be alongside James. I've seen him speak, but we haven't spoken at the same together. But this is very complimentary. I hadn't seen all of his presentation beforehand, so I'm not trying to be Spock, but I am a little bit. Phew. So I lead the Obesity Policy Coalition, and we try and influence through policy and regulatory reform. And we also try and build the evidence base. And I was so pleased that my research study was put up around the lives saved and the money raised and the impact of a 20% health levy on sugary drinks. And that was a piece of evidence that didn't exist. And so I, in fact, paid someone to do that modelling and develop that study. And now we're doing a similar one looking at dental health. So we really focus on the regulatory and policy reform. I work with a team of lawyers, and we have a lot of arguments. Mostly I lose, but robust discussion. And we also work with a dietitian. And here is the Obesity Evidence Hub, which is a policy hub, but it also has information about treatment and prevention of overweight and obesity, and it's an updated website. And just to link back to James's discussion about tobacco, this is, normally I get people to put up their hands and tell me what year this was written, but I'll reveal that. But this is a framework for addressing tobacco control and recommendations for government. And it comes from a book prepared by the UK Royal College of Physicians. And you might be surprised to learn that this was written in 1962. And my point here is that these recommendations haven't really changed over the intervening years. And often we know what to do. Really, the problem is getting governments to act and getting those reforms implemented. And this is showing tobacco consumption in Australia over time. And this is the point where these reports were released, showing that information alone really isn't enough to really bring down smoking prevalence. This dark line is the real price of tobacco. And we can see that that aligns to decreases in consumption. We've also had strong, hard-hitting campaigns, the National Tobacco Campaign, Every Cigarette's Doing You Damage, really raising the urgency around quitting, and smoke-free environments. And those were the three elements that really made a difference. The price increases, the smoke-free environments, changing the social norms around tobacco, and then these hard-hitting ads, together with the support of the Quit Line and other treatments for people addicted to tobacco. So we know the magic synergistic policies, but with obesity prevention and with diet, we need to continue experimenting and pushing all the levers. And the key issues around policy success have already been outlined by James: the prevalence and cost of chronic disease. We need to focus on prevention, as well as, acute care is important, but that seems to be where the focus goes. We need to develop and advocate the case for prevention, including developing the research, create a sense of urgency, the research and evidence, and then the building consensus around policy response. And that's a lot of the work that we do, is around building the consensus. I'm not going to dwell too much on this, you've already seen it, but we have a serious problem of overweight and obesity in our society. And much of this is contributed to by sugary drinks, We have 46% of 18 to 24-year-olds above a healthy weight, and much of this is driven by the highly processed foods, including sugary drinks that they're consuming every day. And there's huge amounts of sugar in these drinks, and there's very little nutrients, even in something like 100% fruit juice. And children, particularly very young children, are also consuming these drinks. And in some communities, like Aboriginal communities, Coca-Cola is called black milk. We've got a really serious issue. And there's a lot of sugar in these drinks, heavily consumed, heavily promoted, very cheap, very available. So what should be done? And what we have is people trying to make changes in an environment that doesn't support them. So we need to change the gradient to make it easier for people to change their behaviours, to prevent them from putting on weight as they age. And the area that we work in is down this end, trying to address the environments, the systemic drivers, the environmental drivers, the policy and economic systems that promote this growth in consumption, the food marketing and supply that promotes this high energy intake through discounts and availability. And these policy interventions are what we work to implement. They have a high effect across the population. They don't widen inequalities, but they're politically difficult. And I think anybody who's worked in this area can attest to that. And this is from the Lancet, and showing that, you know, again, in overweight and obesity and promoting healthy food, governments have a role, restricting marketing to children, legislating around nutrition labelling. We heard about the Health Star rating system, which is not mandatory, tax unhealthy foods, provide healthy eating education, set food standards, a range of things. And some countries have done a lot better than others. And the UK, after Boris Johnson suffered from COVID, is looking to implement a quite broad obesity prevention strategy. So what should be done regarding sugar, which is what we're talking about tonight? And we've been advocating for a health levy on sugary drinks, more than 20%. We think the language of a health levy is good, and putting the levy onto manufacturers, encouraging them to reformulate. Next week, the Forum on Food Regulation is looking at lowering the Health Star rating on 100% fruit juice drinks and making it lower. So it's really important that all our health ministers at that meeting are aware of the problem with fruit juice drinks. They're not healthy. There's currently a consultation on having added sugar on the nutrient information panel of packaged foods. And that would be really important, because if you wanted to put a tax on sugar in foods and drinks, the job's done there. Grouping added sugar on the ingredients panel, there's more than 40 words for sugar, and having a warning or a graphic on sugary drinks. So that's not so wild what James put up, that graphic warning. That is possible under our food regulatory scheme, and teaspoons or sugar cubes are being considered as an option for high sugar drinks. We've also been looking at baby and toddler foods. We see a huge kick up in rates of overweight and obesity in 1 to 3 year olds. And part of the reason is they're drinking drinks which have sugary drinks, and they're also eating foods that are highly processed and high in sugar. This Shreds product was 65% sugar. It had more sugar than many confectionery products, but it looks healthy. It's got the fruit and veg on the front. Heinz did get fined by the ACCC after we made a complaint, but we made a complaint about a lot of products because there's a lot of claims on these foods, particularly around fruit. The sugar in these products comes from processed fruit, and it's in a lot of products for children, even savoury products. At the moment, there's a proposal to limit free sugars added to baby and toddler foods, and as well as sodium, and that's what we're pushing for, compositional limits on foods, because this affects their taste and preferences from a very, very early age. So why is progress so slow? We've got big businesses lobbying against this. We don't have enough calls for change from civil society. Government can't sometimes implement policies. The Health Minister in Victoria said to me, stop asking for a tax on sugary drinks. And I said, I know you can't do it, but often people are asking the wrong people to do the things they can't do. And often we don't have enough evidence of the effects of policies and programs. No country successfully turned around this epidemic of obesity. And I think Margaret Chan, who was the Director General of WHO, said it all, that it's not the failure of individual willpower, it's a failure of political will to take on big business. So we have to get in here and start playing with the commercial interests. And I'm just going to touch on this. This is from the Hillary emails, but it's Coca-Cola Europe's public policy risk matrix and lobby focus, business impact, likelihood to materialise, new or increased product taxes in member states. The business impact would be high and they think it's likely, and this is what they're going to fight back on, and this is very clear. When the Grattan Institute put together their report on sugary drinks taxes, which have been implemented now in 45 jurisdictions with very good impacts, a huge group of industries got together. And I'd seen this in tobacco control, where I started working in the 80s, but I hadn't seen this in the work I've been doing around diets and obesity. The Australian Industry Group, the Beverages Council, the Association of Convenience Stores, the Food and Grocery Council, the Association of National Advertisers, Cane Growers, Sugar Milling, and the Australian Sugar Industry Alliance, representing sectors that contribute more than 311 billion to the economy and account for 15% of the total workforce in Australia. So there you are, there's their political clout in that opening sentence. They said that taxes were the least effective intervention. According to a McKinsey report, they said they had an important role to play. All the framing was around individuals changing their behaviour. It all went back to them providing information. They create the problem, but then they leave it up to the individual to fix it. And they wanted to work with government to make change. And then Barnaby Joyce came out and said the tax office is not going to step in. You have to push your chair away from the table at dinner time and basically do better. So what can we do individually and collectively? And I thought this advice from Nicola Roxon, who had set up the Preventative Health Task Force and made recommendations about tobacco, obesity and alcohol. And she said that we need to be clear about what our ask is and go as a sector. And so we tried to do that with our Tipping the Scales platform. And you can see here, number 6 is the 20% health levy on sugary drinks, food reformulation, advertising controls. This was supported by a range of agencies. It mirrors the AMA and the College of Physicians platforms. And it was front page of The Age and the Sydney Morning Herald around a tax. There's a lot of interest in the media on this issue. And we've got a lot of materials, policy briefs on our websites. And this is all the groups who endorse a health levy on sugary drinks. I think the most significant one of these is the Australian Council of Social Services, who never supported a tax on cigarettes. They didn't speak out against it, but they didn't publicly support it. And we've got a huge group of agencies backing this move. What you can do is, I'm echoing James, we need to make hospitals and healthcare free of junk food and drinks. I'm aware of what happened in Western Australia when that was tried some time ago, but this is really critical. And the Alfred Health, for example, has done a lot of positive work around this. I went to a medical school to give a lecture down at Deakin in 2017. I crawled around and turned all of these off. And at the end of my lecture, I said that all the junk food vending and the Coke machines were broken. So that was my little contribution. The next year and every year since, I have been in a different lecture theatre, and there's been a water fountain. So I don't know if I had an impact. And I think it's really important, as I started, that the medical profession, you are very powerful, you are very influential, you are doing what you can to address this issue. Government needs to do what they can to address this issue, and you have the voice and you have the influence to support them to make changes. Thank you very much.
Thank you so much, Jane. That was fantastic, and I think all of our attendees would be very clear to them your extensive knowledge in the area, and also how to affect change. Because I think it's all too easy to point at a problem, but the wicked issue, the wicked problem, is actually how we achieve change in these difficult areas. And I think both of you have highlighted smoking, our success in the smoking area as a template. It took a long time, but we've achieved extraordinary things, although we are slipping backwards a little with the potential for e-cigarettes, but certainly that's a model that worked and we should be following that. Now, we do have time for a few questions. I might go straight to those if that's okay with everybody. First one, I think it's been partly answered, from Karen Dwyer, asking about the dietary guidelines. And Gary Fettke, who I know is well known to most people, certainly took on a fair bit of personal attacking, and there was a price to pay for challenging things. But James, I know you've had some success here. So would you like to update Karen on how we change the dietary guidelines and where that's up to at the moment?
Sure. In fact, I've been lobbying the NHMRC for many months about the dietary guidelines, and came out with quite a hard-hitting opinion piece in the Canberra Times and the Australian Consolidated Media Group, which went out to 17 publications around the country a couple of months ago, actually. And within a week, within a few days, actually, Greg Hunt came out saying that they're going to review the dietary guidelines. So that was very pleasing to see. But the dietary guidelines, as I mentioned, I didn't really elaborate on it, but are deeply flawed and heavily conflicted by industry influence. And I can give you lots of examples, but just suffice to say that that is a huge, huge problem. And so going forward, the whole process is underway at the moment. Once again, I've been lobbying the NHMRC to actually ensure that the guidelines are created in a fair and independent way. As I mentioned in my presentation, we actually don't need guidelines for healthy people. And if we're saying that the majority of Australians are not healthy, what we should be spending our money on, what we should be focusing on, are guidelines for health educators, health practitioners, dietitians, nutritionists, etc., on how to create the best diet for people with metabolic diseases, in particular obesity, type 2 diabetes and pre-diabetes. Now, this process is going forward. It's going to take 3 to 4 years. So in the meantime, we might lose something like 50,000 people from type 2 diabetes. And there'll probably be in the order of 300,000 new cases. So this is where, in the meantime, we need a very significant awareness strategy. But this will go out to public consultation, and what happens in that process, often industry plays a very loud and prominent role, and we need the public to get behind this, and we need public voices to be heard. But whichever body creates or is involved in the process, and the working group and the committee, really should have absolutely no conflicts of interest, in particular, no conflicts of interest in the ultra-processed food industry.
Absolutely. Thank you. I might flow on to Jane with a similar question, and you can answer that one as well if you want to, Jane. Another one of our attendees has asked, how do you tackle the powerful sugar lobby, especially when the government is clearly dependent on them, not just economically, but politically, or at least they perceive they are. We know that we've got very minimal support from either side of Parliament for any taxation response in this area. So how do we tackle that lobby, the business interests?
Yeah, I think it's about building relationships. I know that things don't look positive with this government, but I think it's about talking to Treasury, which we did with tobacco and the tobacco tax. It's about people understanding what this problem that we face with chronic disease and what the solutions are, and that it would raise money. It's reasonably popular too with the public. And we need to look to what levers we can pull. It's not going to widen inequality either. And all those things are really important. So I think it's building the evidence base and having those conversations, building coalitions, And also what's worked in other countries is having public education campaigns about what the problem is. And the kind of work that James has been doing is really important in getting the public on board, understanding what the problem is, and that leads to the solution. So it helps to start making that cultural shift, which I think is really important.
Thanks, Jane. Now, we're out of time, and I'm going to go to a few more questions if everyone's just got a few more minutes. So just on what individual doctors can do, Anthony Junan's asked, how do we re-educate our cardiologists who are obsessed with fats and anti-lipid drugs and don't seem to acknowledge the benefits of a low-carb diet? And I guess to take that across to other types of doctors, what is our place? And this is probably a question very close to Gary Fettke's heart. What is our place as doctors in giving dietary advice? Do you do it, James, yourself in an ophthalmology consultation, or do you refer to other people? And how do you approach re-educating our profession on some of the insights that you've gathered?
Yeah, it's fascinating, isn't it? And myself as an ophthalmologist, I was seeing the end-stage complications of this disease and never once in the last 30 years, until really the last year, thought about the underlying cause, the root cause, the dietary cause of this, and never once discussing this with my patients. I just felt that it was a responsibility of the GPs, of the endocrinologists, of the dietitians. And I've changed my thinking about that. And actually this year really, in recent months, I have been quizzing my patients and I've been saying to them, you're aware that your disease could be put into remission? And not one of them, quite a number of us, not one of them was aware that that's the case. So either our frontline healthcare workers are not aware themselves, or they're concerned. You know, the Gary Fettke situation, where Gary was actually struck off by APRA, by our medical board, for simply giving patients simple dietary advice of just not eating too much sugar, because he was just every week amputating gangrenous legs. Me, myself, I'm seeing blinding cases every single week. And the Gary situation has opened the way for doctors to be able to give their patients evidence-based dietary advice. So this is really important for doctors to know that this is okay for us to do. And also, you know, our education needs to start at medical school. My son's in second year medical school. He's doing nutrition this term, but it's an elective. This is the most critical health problem in our society at the moment, and going forward, it's only getting bigger, much, much bigger than COVID-19 ever will be. And yet it's an elective in medical school. So this is so important. And also, I looked at his notes, and of course, it says that we should be following the Australian dietary guidelines. So it needs to start with the dietary guidelines. It needs to be, we need a whole system change in medical school, in education of doctors, and we need to make doctors aware and comfortable that they're not going to be hauled up by their regulatory authority if they give dietary advice. But there's so much work that needs to be done. It's not going to happen in a hurry, and it's a complete paradigm shift, as Jane has mentioned. It's huge.
I'd just like to make the point that I really feel that the kind of supports that are there around smoking and around alcohol, it's the same stuff. It's the behavior change, motivational interviewing, and those sort of supports should be opened up to around diet for people. And the New South Wales Get Healthy line's very successful, including with pregnant women. And if you can, you know, these generational issues are really serious as well. So I think we need to get the government to start investing in these sort of supports for people, including education. We've just developed health professionals training for health professionals around this issue. Just 2 questions, simple advice. You know, if you drink sugary drinks, drink water instead and eat more fruit and vegetables. Just 2 questions. But there's a lot of barriers in the same way there was with tobacco. And I think we need to break those down and do much more work.
Thanks.
So it's such a far-reaching awareness strategy, isn't it? I mean, people just not aware. And I mentioned Neil Hansel in my presentation. From the age of 16, when he first started earning money, he was drinking 4 litres of Coke a day through to the age of 26 when he was diagnosed with type 2 diabetes. Now blind in both eyes, 9 amputations, 2 heart attacks. He wasn't aware that he was addicted to sugar. He wasn't aware of the complications that awaited for him. So awareness raising in this process is so critical.
That actually goes very well to another question we have, which is around education and educating our children. Now, we're aware that the dietary guidelines and the way they're implemented in schools is a problem. What about the curriculum in schools? And kids are learning very different stuff to what we learned when we were in school. But is there enough being done there? Is that another area we need to change?
There is some curriculum materials that Sugar Film and Sugar by Half are both involved in curriculum for school children. But I think the other thing is to have canteen guidelines around fundraising. I mean, it used to drive me insane when those chocolate frogs all came home in the box. Cadbury are very aggressive at getting their products into these environments. So I think you need a whole of school approach, not just the curriculum, but what's taught in the curriculum needs to be reflected in the school, what's sold in the canteen and that whole thing. In the same way that we did with tobacco, we made the schools a smoke-free environment. And if you can support children staying healthy, for as long as possible, you're helping build that resilience that James was speaking to.
We have a question here around remote Aboriginal communities and, of course, the extraordinary diabetes rates in children and adults, and clearly linked so strongly to the foods that are available and those that are chosen by people in those communities. Are either of you aware of any programs that have been successful in improving the choices and availability and price of healthy foods in Indigenous communities?
Yes, I'm involved in a CRE with Deakin University, which is about food retail, but they have a big part of that, which is about working with Aboriginal communities and remote stores. It's led by Julie Brimbalcombe. And they found that promoting healthy foods as well as trying to remove the attraction of unhealthy foods, things like taking the large bottles of sugary drinks out of the fridge, it all have a difference. And so those learnings are now being pushed around. We've just had Ken Wyatt do an inquiry into the food supply in remote communities. And that's been really, I'm sure that hasn't reported yet, but I'm sure that it will recommendations. But that was one thing that came out of COVID was the supply in those communities, and it absolutely needs to be improved, and it's certainly driving type 2 diabetes and other chronic disease in those communities. It's
diabolical.
Yeah, it's a human rights abuse in my view, but we hope to see change.
Yeah, it's diabolical. I was speaking to Damon Gamo, who created that Sugar Film the other day, and that sugar movement has been doing a lot of work and managed to implement some change in some of these stores, and then that store gets handed on to the next person who takes over the store, and they go back to their tactics, the same old tactics of selling those sugary drinks. And so, unfortunately, the culture is not handed from one store owners to the next as they progress. So it's something I think that ultimately needs to be mandated, that this is just a diabolical human rights abuse, as you say, Jane.
And they're licensed by the federal government. I mean, they could make conditions on their license. They could work with the community, find out what works, and make those changes. So yeah, they're government stores, those outback stores.
So that's obviously one area that AMA can advocate. Last question for the night. What would each of you like to see the Australian Medical Association doing in this space? How can we assist to create real change in this important public health area? Maybe James first, you're off mute.
Sure. I mean, the three big things for me this year: raising awareness, the dietary guidelines, and the opportunity to put type 2 diabetes into remission. So I think dietary guidelines are probably not in the realm of the AMA. Awareness raising is in the realm of the Department of Health, the government. Ultimately, I think the ability to put type 2 diabetes into remission. I mentioned before that there are 3 proven methods. I'm not saying that we should be using bariatric surgery. That's absolutely the last line strategy. But there are 2 proven dietary methods. Doing major abdominal surgery on basically a normal organ, the stomach, when you have a dietary solution, it just makes no sense to me. So we should be pushing a dietary cure for what is in essence a dietary disease. And this is where I think the AMA can make real change. There are, as I said, over 100 controlled trials that show that a dietary solution is possible. And yet, you know, we're constantly meeting resistance from the various groups that are involved in this process. You know, how many studies do we need to show that this works? We have patients now going out and doing it themselves. We have GPs going it alone and having great success. This is something that needs to be embraced. It needs to be part of the National Diabetes Strategy. In fact, I'm on the expert advisory group, and we now have remission of type 2 diabetes as part of the goals of the national strategy. So that's a promising step, and I think we will see this going forward in a positive way, I hope.
Excellent. I have to say I've been pointing a lot of my patients in the direction of Michael Mosley's books in an attempt just to get something done, because it is, you know, we just don't have the tools at our disposal to really have these conversations with patients properly. We need
an Australian solution.
Yep. Jane?
I think building these referral pathways is really critical on the one hand for the medical profession and other health professionals. But I also think safety in numbers. I mean, we're up against some very slick operators, but we have health of the population on our side. We're not trying to defend our profits. And it's a long game. And I think there's a lot of policy on the table right now. Industry are going to fight really hard against added sugar on the label. And that is the key to a lot of foundational work that can follow. So we really need to get that done. And I think there's a lot of interesting policy elements that I outlined, and they're current and happening right now. So I think if we can push in the same direction and then think about the other supports that the public need to make change and embed those in the health system, I think that would really make a difference. Because coming from tobacco control, I can see that there are these gaps. There's not a continuum. There's a lot of holes. But I think the AMA is a very powerful, very experienced advocacy group. And I think that if you pick these issues up, I think you could make a real difference.
That sounds like a pretty good place to finish. And certainly, I'd like to thank you both for your time. The AMA will be doing more in this space. We recognise that these are, as you mentioned, Jane, long games, but we can't be defeated by the fact that some of us turn over fairly quickly, like our Australian of the Year, gets his time in the sun, and then it's someone else. And certainly for AMA presidents and other medical representatives, we come and we go, but we need to play these long games. We need to have the resilience that James talked about, and we need to, I guess, marshal our forces, bring our patients along on this journey, bring our members along on the journey, and that is what politicians will ultimately respond to when they say that they don't have a choice. So really looking forward to working with both of you in the future on further practical things that we can do to make a difference here. I'd like to also thank all our attendees for coming along and joining in the conversation through your questions. I think this may be available in some format. So if you want to suggest it to anybody who wasn't able to come, it'll probably be available on our website, I would imagine. And one last thanks to our experienced and very interesting presenters tonight. Cheers. And good night.
Thanks, Emma. Thanks, Jane. Thanks, AMA.
Thank you.
Thanks, everyone.
Bye-bye.
Bye.